Very good evening, everyone. Uh, let's begin the very last lecture of this Farre series for your prof exam. Here in this section, we are going to discuss abdomen as a system. So we'll cover GI and liver. And along with that, I'll be open to you all. If you want me to repeat any topic or you want to add any topic that you feel that your university is very fond of asking, then if time permits, we will take on that. Right? So, hello everyone. Hello, hello. Okay, so without further ado, we should begin. So, what all you can expect from the abdomen section per se, the GI section and the liver section. So, firstly, we have some congenital disorders like Hirschsprung disorder, Hirschsprung disease. Then we have diarrheas and dehydration. In diarrheas, the university people are particularly fond of asking about persistent diarrheas. Hello, everyone. Hello, Sannyasi Pandit. Hello, crazy loser. Hello, Pratyusha. Okay, so Hirschsprung disease, we have diarrhea, persistent diarrhea, dehydration assessment and management. We have celiac disease, and from the liver section, Wilson's disease and EHBA, that is extrahepatic biliary atresia. These are the topics that are frequently asked in your university exam, as well as if you further go on to give your NEET PG, your FMG, your INICT. These are actually very hot favorite topics, especially the dehydration assessment and management. Each and every year in one exam or so, you are going to find this question. Okay, so without further ado, let's start with the first topic, that is Hirschsprung disease. This Hirschsprung disease, the other name if you look at it, is aganglionosis. Aganglionosis. So what is happening? We all know there is an enteric nervous system. We have oreblac plexus, Meissner's plexus. There is the network, a nervous system network in my GIT. That is very important for the motility of the gut, the propulsive motility of the gut. Here in Hirschsprung disease, that ganglion is absent. That nervous connection is absent. So what will happen? Because of this absent nervous connection, a segment won't relax. A segment won't relax. It will stay contracted. So let's read more about it. So aganglionosis, if you take the gender predisposition, then it is seen it is more common in males as compared to females. In fact, 4:1 ratio, 4 times more common in males as compared to females. And the most common area that is affected, that means the most common area where this ganglion would be absent, is the rectosigmoid region. It is the rectosigmoid region. Why it is happening? Because there is failure of migration of neural crest cells that form the nervous connection over there. So there is no nerve in that particular segment, and that segment is known as aganglionic segment. Because there is no nerve connection over there, that particular segment, it fails to relax. So that particular segment, this aganglionic segment, will fail to relax. And because of that failure to relaxation, what will happen? This segment will stay contracted. So it will stay contracted. And what will happen to the segment that is just prior to that contracted segment? That will get dilated, right? So look at here. This is the affected segment. It is contracted. And because the segment is contracted, my feces, my fecal matter won't get passed through. So my proximal segment, it will get dilated. So because of this failure to relax, the proximal segment will be dilated. Proximal segment will be dilated. So this is what happens in cases of Hirschsprung disease. So now coming to the clinical features. After the pathogenesis, let's understand the clinical features. What would be the clinical features? One segment of the gut is contracted. It is not getting relaxed. So my fecal matter won't pass through it. And the most common region is the rectosigmoid region, which is very low. So the first presentation would be the neonatal period. There will be delayed passage of meconium. So a child who presents with delayed passage of meconium. Delayed passage of meconium. Right. And because the feces is not getting passed, how will the abdomen look to you? The abdomen would be distended, abdomen would look fuller, so abdominal distension would be there. Abdominal distension would be there. If I do a per rectal examination, what would be there? Would there be any feces? No, there wouldn't be any feces. The feces is not getting passed through that contracted segment, so rectum would be empty. There will be empty rectum. And a very typical sign, when you pass your finger through the rectum, do the digital rectal examination, it can sometimes stimulate the gut, and because of that stimulation there will be a gush, a sudden expulsion of the meconium happening. So very typical sign on digital rectal examination, there is sudden expulsion of the meconium. Sudden expulsion of meconium. This is very typical over here. Right? The investigations best would be biopsy, but apart from that, we can check the pressure in the rectum by rectal manometry. So rectal manometry is a investigation that we go for, but the best would be to go for biopsy. In biopsy, what do I have to look for? In biopsy, I have to look for the nerve segments. If nerves are absent, this is aganglionosis, Hirschsprung disease. So what will you see in the biopsy? You will see the absence of the ganglion, and the nerve fibers would be hypertrophied, and staining is very important here to remember. Staining with acetylcholinesterase would be positive. So there will be absence of ganglions, there will be hypertrophic nerve fibers, and there will be positive staining with acetylcholinesterase. So these are the features, investigations that you go for in cases of Hirschsprung disease. The treatment here is surgical. We do resection and anastomosis. The segment that is affected, we cut that segment and join the normal segments together. So resection and anastomosis. So resection and anastomosis. Or instead of cutting that gut segment, what can we do? Instead of cutting that gut segment, what all we can do? We can do a pull through procedure, that you pull the normal gut through that affected gut, right? Pull through procedure. This is better explained in your surgery lectures. So there are two procedures, Duhamel and Swave. These are the pull through procedures. Right, so very fairly easy topic, Hirschsprung disease. Now let's move to the next topic, that is diarrheas. And in diarrheas, a very important topic for you is persistent diarrhea. What do I mean by persistent diarrhea? Any diarrhea, persistent diarrhea, any diarrhea which is lasting for more than 14 days is persistent diarrhea. Look at this picture. This picture should always be there in your mind. What is happening in this picture? Not a very scenic look to look at. This is the potty area of a child, and you can look around the anus. There is redness excoriation. There is perianal excoriation. Can you appreciate over here? Perianal excoriation. What happens in persistent diarrheas? In persistent diarrheas, there is lot of stool passing through. Right, for a prolonged duration of time, loose stools have been happening. So because for a long duration loose stools are there will be sloughing of the intestinal epithelial cells, and these intestinal epithelial cells have the brush border enzymes, the lactases, and because of that loss of lactases, what will happen when this child will drink milk? No lactase is there, so that milk would be acted upon by colonic bacteria and converted into lactic acid and hydrogen gas. This lactic acid that is coming through the anus will cause excoriation of the perianal area, and hydrogen will cause gassy stool. So mother will say that the child is passing very gassy stools, and that's why. And also, if when you look at the anal area, there is a typical excoriation, the rash is there. Right? So what is happening due to persistent diarrheas? There is persistent diarrhea, there is prolonged diarrheas. So because of that, there is sloughing of intestinal epithelium. And because of that, there will be secondary lactase deficiency. Secondary lactase deficiency. Why I am telling it as secondary lactase deficiency? What happens in primary lactase deficiency? In a primary lactase deficiency, there is some genetic problem that the body is not producing lactase. But here, secondary to the diarrhea, the child is developing this lactase deficiency, right? So this is secondary lactase deficiency. So what is going to happen when the child takes milk? When the child takes milk, what is going to happen? This lactose that is in the milk would be acted upon by my colonic bacteria, and that would be converted into lactic acid and hydrogen gas. This lactic acid causes this excoriation, and these hydrogen gas will produce gassy stools. Right, so this is nothing but your persistent diarrhea. And why do we see perianal excoriation around your anus? Perianal excoriation, this swelling around the anus, Zaid and Sari, is nothing but this excoriation that is caused by lactic acid. If you throw acid at your skin, it will definitely be excoriated. So this is the picture, right? How will you manage over here? The first management would be to manage the dehydration. Every time in cases of diarrheas, in cases of dehydration, you have two things: manage the dehydration and do zinc supplementation. So the basis will stay the same. We will manage the dehydration over here, because for a long time this child is losing so much water out of the body in the form of stools, and provide zinc supplementation. Apart from that, here in persistent diarrheas, we add on vitamin A supplementation also. That is thought to improve the intestinal integrity, help in intestinal repair. So we add vitamin A supplements too. And we all know what are the dosage of vitamin A supplementation. If the child is less than 6 months, it is 50,000 international units. 6 months to 12 months, it is 1 lakh international units. After 12 months, it is 2 lakh international units. Right, so this is the dosage of supplementation. For zinc also, we know if the child is less than 6 months, we give 10 mg per day, and in cases of above 6 month old, we give 20 mg per day, and this we have to continue for at least 14 days. At least 14 days. Dehydration management we will study further on. This was the basic management. But what is the culprit over here? The culprit here is this secondary lactase deficiency. If I don't give lactose, these problems won't happen, right? So the fourth prong in the management is diet. I have to change the diet. Initially, we take this child on a low lactose diet. Low lactose diet. So we tell the mother, if you were giving milk earlier, now don't give plain milk. You can dilute the milk. Make the diet low lactose diet. How? We can give rice milk gruel. We can give suji ki kheer, suji milk gruel. So rice, khichdi, kheer, these type of meal would be appropriate for the child now. Suji milk. Right? By this, we are diluting the amount of lactose that the child was consuming earlier. If the child still has diarrhea, not responding to this low lactose diet, then we completely omit lactose from the diet. So we give no lactose diet. No lactose diet. No lactose means now I will tell the mother to give plain cereals, like plain dalia. Make the dalia with water. Mother can make oats with water, right? So plain cereals now you give, plain carbohydrates. If on plain carbohydrates also the child is not responding, then no lactose, no starch. So plain protein meals like chicken soup, egg white, all of these the mother has to give. So here now no lactose, no starch. Simple monosaccharides and chicken proteins like chicken puree, right? Eggs, all of these things you can give. right? So this is about the management of persistent diarrhea. So by now we have covered Hirschsprung disease and persistent diarrhea. Now moving to the hot favorite topic of examiners in your university exam, your INICT exam, your FMG exam, your NEET PG exam, that is dehydration assessment and management, right? Children usually accept that protein. If not, then we have to just wait and watch, give supplements, ensure that the child doesn't land up into severe dehydration. This is a very simple meal. The child should improve on proteins. If not, then special formulas, isolates we can give. Something has to go into the gut of the child, right? And if the child is very sick and not able to accept orally, then TPN is the very last resort. That is in the situations when the child turns very sick, lands up into the ICU. Then we do that. Usually on dietary management and simple things, the children improve. They are very resilient. But if not and lands up very sick, then we have parenteral nutrition to cover that. Right? So let's start with dehydration assessment. Yesterday, we started with recipe and discussed the IMNCI guidelines, no pneumonia, pneumonia, and severe pneumonia. Dehydration management is very similar to that and very different from that also. So whenever we are assessing dehydration, there are three types: no dehydration, some dehydration, severe dehydration. No dehydration means the child is not dehydrated. Just whatever the losses the child is going to have, you have to replace that. Second category is some dehydration. That means the child has some degree of dehydration that can be corrected if you do enough rehydration, right? And then we have severe dehydration. That means the child is very severely dehydrated. Now you have to vigorously do rehydration. So let's understand first what is this no dehydration, some, and severe dehydration. So no dehydration, I told you, this child is not dehydrated at all, just passing loose stools and vomiting here and there. So the general status here is going to be alert. This child is going to be alert. If you do skin pinch in this child, because this child does not has dehydration, this child's skin pinch will be very immediate, right? So skin pinch or skin recoil would be immediate. So there is immediate recoil. If you check the mucosa of this child, because this child has no dehydration, would be moist. Eyes would also look normal. When you offer water to this child because has no dehydration will very calmly, just like a gentleman will drink water, very calmly, right? So the thirst would also be normal. But what happens in some dehydration, now this child has developed some degree of dehydration. So this child will turn very irritable, right? So this child will be irritable because of that dehydration. When you look at the skin pinch, now the skin pinch would be slow, but within 2 seconds this should come back. Oral mucosa would be dry, eyes would look sunken. And when you offer water to this child, because this child has some dehydration, this child will very eagerly drink water, very eagerly drink water. So the thirst would increase very eagerly, this child will drink water. Now let's move to the last category, that is severe dehydration. Now this child is very severely dehydrated, so this child will be very lethargic, very comatose, very thin child, right? So comatose child would be there, a very lethargic child would be there. The skin pinch would be very slow. That means more than 2 seconds. Oral mucosa would be very dry, eyes would be very sunken. And when you offer water to this child, what will happen? This child is very lethargic, comatose. The child won't be able to drink water, right? So the child's thirst will be decreased. Child would be unable to drink water, unable to drink water. Now, how will you manage? No dehydration, I manage with plan A. Some dehydration, I give plan B. And severe, I give plan C. Now let's understand what are these plan A, plan B, and plan C. Right? Plan A was for no dehydration. Here I typically do home-based treatment. I give oral ORS, to this child. This is the fluid of choice, right? I tell the mother that you just have to replace the ongoing losses. The child is not in dehydration. You don't need to rehydrate the child. Just replace the ongoing losses. How you're going to replace the ongoing losses? Per loose stool. With each loose stool, you have to offer this ORS. How much? If the child is less than 6 months, 50 ml. 6 months to 2 years, 50 to 100 ml. After 2 years, 200 ml or ad lib. That means how much, whatever quantity the child can drink, you can let the child have that ad lib, right? A simple rule is 10 ml per kg, 10 ml per kg. So if it is a 10 kg child, then you give 100 ml. This is the logic behind that. So per loose stool, this you have to replace. With every loss, you have to give back. This is the management of no dehydration, plan A. Very simple. Now let's move to plan B. In plan B, the child has some degree of dehydration, but the child is very eagerly drinking water, very eagerly able to rehydrate himself. So here, again, I give home-based therapy. But I know this child has some degree of dehydration and can land up into severe dehydration if not treated well. So I will also ask the child to follow up. Here again, because the child can drink, I will give oral ORS. But I need to rehydrate here. Just replacing the ongoing losses won't help. I need to rehydrate because some degree of dehydration is there. So this rehydration, correction of dehydration would be done over 4 hours. I give 75 ml per kg of ORS over the next 4 hours. So if a child comes to me now, 10 kg child comes to me now in some dehydration, how will I rehydrate? I will tell the mother to give 750 ml, that is 75 into 10 over the next 4 hours. But side by side, we need to replace the ongoing losses and ensure that the child is getting daily maintenance fluids. What are these maintenance fluids? You all know what are these maintenance fluids. These maintenance fluid is something that we all need for our daily performance. You, me, everyone. This is something that no dehydration child would also require. But here we have to ensure that these maintenance fluids are given. How do we calculate the maintenance fluid? This is calculated by a formula that is known as Holiday-Cigar method. Holiday-Cigar method. So till 10 kgs, for the first 10 kg of the weight, we give 100 ml per kg. 100 ml per kg. For the next 10 kg, we give 50 ml per kg. And subsequently, for every kg, you add 20 ml per kg. 20 ml per kg. So I have a scenario for you. So if say I have a 21 kg child. So the first 10 kgs would be 1000 ml. Next 10 kgs would be 500 ml. And next 1 kg would be 20 ml. So total would be 1520 ml. This is per day. Per day the child requires this amount. This you, me, everyone requires. If you know your weight, you can also calculate what are the maintenance fluid that is required by your body. This is the least amount that you need to take every day, right? So this is Holiday-Cigar method by which we calculate the maintenance fluid. So this was simple some dehydration. Now let's move to severe dehydration. What happens in severe dehydration? In severe dehydration, the child is comatose, not able to take anything from mouth. So here the management is going to be hospital management. I cannot send this child home, right? This child is very comatose, lethargic. So hospital management has to be done over here. And because the child is unable to drink, I will give IV fluids. And the choice of fluids here is RL, Ringer lactate, right? Here also the 3 steps will stay the same. I need to rehydrate the child, I need to replace the ongoing losses, and I have to ensure the maintenance fluid. But here rehydration would be very vigorous. In some dehydration, I was giving over 4 hours 75 ml per kg. But here we give 100 ml per kg. Here we give 100 ml per kg. And this 100 ml is further divided into 30-70. 30 ml per kg and 70 ml per kg, depending upon the age of the child. If the child is very small, chota child, then definitely I cannot give so much fluid in one go. I will slowly give the fluid. So in a child who is less than 1 year, you give this 30 ml per kg over 1 hour, followed by the 70 ml per kg over 5 hours. And if the child is above 1 year, then this can be given over 30 minutes. And this can be given over 2.5 hours. So half of that. So total 6 hours. Here we have 3 hours. right? So this is how you're going to manage no, some, and severe dehydration. Any doubt regarding the management of dehydration, assessment of dehydration, because this is a very important topic. If there is any doubt, please drop that down in the comment section, or else we can move to the next topic. This is a very important topic. Remember, dehydration assessment, persistent diarrheas, management of dehydration. You'll get a scenario in the question in cases of your competitive exam. Also in your vivas, in placards, you can get a scenario, and the examiner can ask you what type of plan you're going to give and what would be the amount of fluid that you need to give for this form of dehydration, right? So now let's move on to some few topics that I wanted to discuss in cases of dehydration and diarrhea management, because Viva favorite questions are there, right? Some things are very factual and that you need to mug up. So usually these childhood diarrheas are viral diarrheas. We don't give antibiotics, but in certain situations antibiotics are prescribed. What are these situations? If the child has sepsis, if this is a very severely malnourished child, SAM child, if this child has some sort of immunodeficiency, right? If there is dysentery, dysentery means there is blood along with loose stools. Dysentery, most common organism is Shigella. So here we will need antibiotics like third generation cephalosporin. Also, the stools are rice watery stools. That means cholera, Vibrio cholerae. So it is bacteria. Again, we have to add antibiotic doxycycline. So if there is rice water stools, you have to add doxy. So remember these 5 conditions where you are going to add antibiotics also, apart from this dehydration management and zinc supplementation, vitamin A supplementation, right? So this is about the indication of antibiotics. Now let's revise this ORS formulation, because in Viva table there will be an ORS packet over there, and for a second only the examiner will give, tell me what it is, and we'll take it back from you, so that you don't look at the ingredients and the concentration of ingredients that is in there. So remember what all there is in WHO ORS. It is reduced osmolality ORS. We have sodium, glucose, potassium, chloride, citrate. How to remember? Sodium and glucose equal. Sodium and glucose equal, because the same transporter is required for sodium and glucose. So equal amounts of sodium, 75, 75. What about potassium? Potassium is 20. What about chloride and citrate? Remember, this chloride and citrate together are 75. So chloride is 65, citrate is 10. Total it is 245 milliosmol per liter, right? This is WHO ORS. Now if you tell this to the examiner won't get satisfied. The examiner will ask, can you tell me about ReSoMal? What is ReSoMal? ReSoMal stands for rehydration solution for the malnourished. How is it different from WHO ORS? This would be the follow-up question. So this rehydration solution for the malnourished is developed from the SAM child. The SAM child cannot process this high amount of sodium that is there in the WHO ORS. So that's why this rehydration solution for malnourished is formed. So here sodium is reduced to 45. Glucose is increased because they need more glucose. Potassium is 40. Chloride and citrate are similar, 70 and 7. And along with that, there is added magnesium, 3 millimole per liter. 3 millimole per liter. Overall osmolality here is 300. So overall osmolality is 300, but there is sodium is less, glucose is higher, potassium is also higher, right? So this is the difference between normal WHO ORS and ReSoMal. With that, let's move to the next topic, that is celiac disease. Celiac disease. Celiac disease is very fairly common in North, because our predominant diet is gluten only, wheat, chapati. We take almost every day, right? So more presentation is in the North. In South, the major staple meals are rice based. So celiac disease presentation is very less down there in South, because their diet is already gluten free. So mostly you're going to see celiac disease in north, up in north. So what all do you see in celiac disease? Usually the presentation would be when you introduce the wheat or gluten to this child. So after 6 months, till 6 months, the child will be exclusively breastfed. So after 6 months, when introduction of gluten to the diet is there, the child will develop symptoms. We all know celiac disease is a hypersensitivity to gluten, right? This gluten has this protein, gliadin protein, which is the culprit. In which all things do you find this gluten? The mnemonic we all understand, rob, right? Wheat, rye, oats, barley. Remember this oats. Oats, I want to discuss oats, catchword oats. This oats and wheat are usually processed in the same farm. So there is some form of contamination with the wheat. But if you have pure oats are actually gluten free. So pure oats are gluten free. So until unless you have your own farm of oats and you are very sure that there is no contamination, you can have these pure oats. Otherwise, in general, we don't recommend oats to these celiac disease children. So what happens over here? In celiac disease, celiac disease patients, there is a certain genetic predisposition, and because of that, there is this hypersensitivity reaction which is T cell mediated, right? So genetic predisposition, we know HLA-DQ2 and DQ8. This is the genetic predisposition, and on exposure to the gluten gliadin protein, there is T cell mediated hypersensitivity reaction and destruction of the intestinal epithelium. So because my intestinal epithelium is destructed, now what will happen? There will be enough absorption of the good things that my diet gives? No. So will this child thrive? Will the weight of the child increase? No, the child will have failure to thrive. So this child will have failure to thrive. And because nothing is getting absorbed, my intestinal lining is disturbed, this child is going to have chronic diarrheas. Chronic diarrheas. Right? This child will have anemias. Anemia is in fact a very important presentation of celiac disease. No other problem you will see, but anemic child, you should always suspect celiac disease. Apart from the intestinal manifestation, there are certain extra-intestinal manifestations too. Like in skin, you see a particular manifestation that is known as dermatitis herpetiformis. Dermatitis herpetiformis. Also, these children have more predisposition to develop leukemias, NHLs, right? NHLs, high chances of NHL, non-Hodgkin leukemia, lymphomas, right? And certain autoimmune conditions are also associated with celiac disease. So if you find these autoimmune conditions or you find celiac disease, you screen for the others or vice versa, right? So for example, if I get a child with type 1 diabetes, I will also check for celiac disease in that child. If I see a child with autoimmune thyroiditis, I will also look for celiac disease, and vice versa. If a celiac disease child comes to me, I will also check his sugars for screening of type 1 diabetes because they are very closely associated. Okay, so this is about the presentations and manifestations of celiac disease. Now, what all investigations you will go for? We have certain antibodies that can give me a clue. We have certain screening antibodies, certain specific antibodies. So, anti-TTG-IgA, tissue transglutaminase, IgA, is very sensitive. And anti-EMA, endomycin A antigen, anti-EMA is specific, right? But confirmatory would be biopsy to document the destruction. So biopsy we do of certain segments, and there is certain Marsh staging that you see in study in pathology. What happens here? Normally, if I look at my intestinal lining, there is villi and crypts. Villi and crypts. villi and crypts. This is my lining, right? Brush border like villi and crypts. This villi and crypts is important for the absorption. But here there is destruction of this lining. So what happens? These villi would be blunted. This villi would be blunted. So there will be villus atrophy. So these villi will be very atrophic. And what will happen to the crypts? The depressions, they have crypts hyperplasia. So there will be crypts hyperplasia. And normally you have inflammatory cells, my lymphocytes, intraepithelial lymphocytes here and there. Here, because of this destruction, the intraepithelial lymphocytes would be increased. You will see inflammation over here. The intraepithelial lymphocytes will increase. So this is what you see in biopsy. You see first there is villus atrophy, villi atrophy, villus atrophy. There is hyperplasia of the crypt, crypt hyperplasia. And lastly, there is increase in the number of intraepithelial lymphocytes. The management here is nothing, just to eliminate the gluten in the diet. We know the culprit is gluten. Remove the gluten from diet and the child will thrive. So we give gluten-free diet. But before checking, before consuming any gluten-free labeled products, read the label carefully. Think is considered gluten-free when the amount of gluten is less than 20 parts per million. 20 parts per million. Then only it is gluten-free. Right? So there can be false marketing in the market, and you might see a packaged food that says that this is gluten free, but when you check the ingredients, it's more than 20 ppm. So ensure less than 20 ppm gluten is there in that product. And once you take this child on gluten free diet, this child response is seen within 3 months, that is 12 weeks. So you see a response in 12 weeks. Right, so this is all about your celiac disease. Moving to the liver section now. So we are done with the GI part. Now let's move to the liver section. And liver section, I'm going to discuss two things: Wilson's disease and EHBA, that is extrahepatic biliary atresia. So without further ado, let's start. But if you have any doubt regarding anything that we have discussed till now, I'm more than happy to repeat it. If there is any doubt, do let me know. Okay, I believe there is no such doubt. So let's start. Right, we are starting with Wilson's disease. So Wilson's disease is a very important metabolic liver disease that examiners are very fond of asking. Let's start with the genetics first. What is the inheritance pattern here? It is autosomal recessive. That means again siblings, you will see the same. Consanguineous marriage, again that. So what is the mutation that you see over here? It is an autosomal recessive disease, and the chromosome that is affected is chromosome number 13. On chromosome number 13, we have a gene, ATP7B gene, ATP7B gene. Normally, what this gene does, this gene normally, the function of this gene is to excrete copper into the bile, excrete copper in the bile, and incorporate the copper in my body to ceruloplasmin, the carrier of this copper, right? So incorporate copper into ceruloplasmin. This is the normal function. So what will happen if this is abnormal, there is some mutation? What will happen to the copper in my body? Normally copper excretion was happening through it. If it is defected, my copper levels in the body will increase. So copper levels in my body will increase, the unbound copper will increase, and the ceruloplasmin levels will decrease. Right? So this is the scenario that you are going to see. Now why I am worried? Because this unbound copper, high levels of copper in my body are toxic. These are toxic. That's why I am worried in this condition. Right, so let's see what this toxic copper is going to do to my body. Let's go system wise. Firstly, in liver, this high amounts of copper can lead to chronic liver disease, cirrhosis, and usually the presentation is after 1 to 2 years of age. In eye, this unbound copper will get deposited and cause this classical ring, that is Kaiser-Fresher ring, KF ring. Also cataract, sunflower cataracts are seen over here. In joints, it will cause joint pain, arthralgias. In blood, there will be hemolysis. In our central nervous system, we see affection of a particular basal ganglia region. And because the basal ganglia is affected, you are going to see extrapyramidal symptoms. And also certain neuropsychiatric manifestations are seen because of this copper. The first thing the child can tell you that there is decline in the scholastic performance, then behavioral changes can also be there. So this is all about the CNS problems. Now let's discuss the investigations. We have certain screening investigation, certain confirmatory investigation. So screening, how can we do the screening? We check for urinary copper excretion. If the urinary copper excretion 24 hours urinary copper secretion is higher, then this is definitely a good sign for Wilson's disease. We can also check for the ceruloplasmin levels. If the ceruloplasmin levels are low, that is again pointing towards my Wilson's disease. But the confirmatory would be biopsy. We check the liver. We take the liver biopsy and check how much copper content is there. If the copper content there is more than 250 micrograms per gram of dry weight of liver, this is confirmatory of Wilson's disease, right? Now, how will you manage this child? First management is diet only. You avoid copper containing foods like chocolates, nuts, shellfish. We do chelation of this copper by D-penicillamine, and zinc is also added. Zinc, what does zinc do? It decreases the absorption of copper from my gut. Right, so this is how you manage your Wilson's disease child. So with that, we move to the last topic of today's session, that is EHBA, extrahepatic biliary atresia. So what happens in EHBA? Extrahepatic biliary atresia, the name itself has extrahepatic, that means my extrahepatic bile ducts, they are now atretic. They have collapsed or obliterated. So it is a progressive fibro-obliterative disease. It is a progressive fibro-obliterative disease. That means there is fibrosis which is progressively happening in my extrahepatic bile ducts. So if there is collapse or obliteration of my extrahepatic bile ducts, will my bile flow down to my gut? No. Bile will stay there in my liver and expel into the circulation. So there is bile flow obstruction, and because of that spillage into outside into my circulation, there will be persistent jaundice. So what are the clinical features that you see over here? We see persistent jaundice, and because there is bile flow obstruction, how will my stools look? My stools would be pale clay colored stools. Urine appears very dark. There is hepatomegaly, and in late stages there can be splenomegaly as well when the obstruction increases too much. The diagnosis will include checking the lab test for conjugated hyperbil, elevated AST/ALT, and GGT. On imaging, you see a particular sign, a triangular cord sign, and liver biopsy shows the portal tract expansion and bile duct proliferation bile plugs. The gold standard here is intraoperative cholangiography. This intraoperative cholangiography will tell me, confirm that there is duct obstruction or duct patency. Right, moving to the management. Management is surgical. What is important here? That the surgical management has to be done within 60 days. After that, the prognosis is very poor. So best to do this surgical connection to drain bile. This is known as Kasai's procedure, Kasai's Portoenterostomy. Here, what do? We directly take make a connection of a bile flow into the gut, bypass that obliterative segment. And for failed Kasai or advanced liver disease, we can go for liver transplantation. What is important here is that for prognosis to be better, this procedure has to be done within 60 days. If we do early Kasai, that will improve the bile drainage and survival. Delay will lead to irreversible liver damage, and that would then require transplantation. Follow-up, we go for growth monitoring, LFTs, and screening for complications like cholangitis and portal hypertension. With that, we cover our abdomen part, we covered GI and liver. If there is any doubt regarding any of these, please drop that down in the comment section. And we are open to any suggestions that you want me to include, any topic that you want me to repeat, or you find that very confusing, we can go about that. Otherwise, we can end the session today. If there is any doubt, please drop that down in the comment section. Kasai Portoenterostomy, this you must have studied in surgery. So what is happening? This is my liver. This is my liver. You know, there are intrahepatic bile duct, then we have extrahepatic bile duct, and through that, my bile is going into my gut. But in Kasai's procedure, what do? This obliterated segment we have to bypass. So we make a direct connection between the bile ducts and the gut so that bile can be drained out. Is it fine now? Samantha, if it is fine, Sutapa Samantha. I believe I was snow enough. And this diagrammatic, however poor representation is there, you get the gist that we have to make we have to bypass this bile flow obstruction. So we directly connect the bile duct to the bile flow to the gut so that bile can be drained. Okay. Okay, let's end the section then. This Farre series you can explore on the MedEd app. We also have annotated notes available. You can check that out in the pinned comment. Right, and all other subjects, final year subjects, the Farre series is going on. We have similar series for all the 4 years, 4 prof exams. Right, so thank you, have a nice evening, have good dinner. We'll meet in the next class.